So good morning, good afternoon, good evening, everyone. Welcome to the ATS International Health Committee webinar on navigating national lung cancer screening programs, which is a joint session with Thoracic Society Australia and New Zealand. I'm Yit Kaur from Monash University in Melbourne, Australia. I'm the current member of the ATS International Health Committee and also the current chair of the TSNZ Education and Training Subcommittee. Together with me is Dr. Jun Yong Choi, who is an assistant professor in the Division of Pulmonary and Critical Care Medicine in Incheon St. Mary's Hospital, the Catholic University of Korea. So welcome, Jun. I'll hand over to you to kick off the first talk of the day. Thanks, Jun.
Hello, everyone. So before we start, I want to tell you that if you have any questions or comments for our speakers, please feel free to submit them at any time using the Q&A function located at the bottom of your Zoom window, and we'll address them during the discussion session. So our first speaker is Dr. Tracy Leung. Dr. Leung is the Director of Interventional Pulmonology and Respiratory Clinical Lead in Lung Cancer in Austin Health in Melbourne. She's the chair of the Lung Cancer Working Party for the Thoracic Society of Australia and New Zealand, and chair of Early Non-small cell lung cancer group in the Thoracic Oncology Group of Australia. So Tracy, please.
Thanks, Dr. Choi. I'll start to share my slides. And are you able to see my presentation?
Yep, that's great. Thanks,
Great.
Tracy.
Well, thank you so much. So thank you to the ATS for the kind invitation to speak about the Australian Lung Cancer Screening Program, and just to give a couple of insights into the first couple of months of this program. So first, just a bit of a brief description of the similarities and the differences between Australia and the rest of the world are relevant to lung cancer. So in terms of the lung cancer statistics, Australia very much mirrors the global picture. So you can see here that lung cancer is still the fourth most often diagnosed cancer in both men and women, although it is rising in women, but it is still the leading cause of cancer death and has been so for the last few decades in Australia. But there are some unique characteristics about Australia that have definitely influenced aspects of our screening program. So Australia's population is very heavily concentrated along the eastern and the southeastern coasts. You can see here in the red and in the orange. But about a third of the population live in what we call rural and remote areas where the access to healthcare is quite challenging. And this has translated into over 30% more lung cancer diagnoses and 12% lower survival from lung cancer in this particular population. In Australia, we also are blessed with a rich diversity of Indigenous people. And although they only represent 3.3% of our total population, they comprise hundreds of distinct groups, often with their own languages. And compared with non-Indigenous Australians, Indigenous people are twice as more likely to be diagnosed with and twice as more likely to die from lung cancer compared to their non-Indigenous counterparts. And so when we were planning the Australian program, it was specifically designed to improve the equity for these particular vulnerable groups. And so after 6 years of consultation, the federally funded program was launched in July of this year. And this is a flow chart that depicts our program protocol, which I'll now step you through. So firstly, in terms of our screening eligibility criteria, so our program is quite tight. It is for people aged between 50 to 70 who either currently smoke or have stopped smoking in the last 10 years and have at least a 30-pack year history of smoking and who do not have any signs or symptoms of lung cancer. In the Australian program, this is heavily reliant on general practitioners who are in our community to recruit and enrol participants in a centralised cancer screening platform, which is called the National Cancer Screening Register, or the NCSR. And through this platform, patients have their CT reports uploaded, they receive reminders for their follow-up scans, and clinicians can submit the eventual diagnosis of any screen-detected findings. In terms of the actual reporting of the scans, this is through a synoptic report, and we have a unique protocol where the baseline CT is reported using a modified version of the PanCan risk tool, but then the interval follow-up CT scans use a modified version of the LungRADS tool. And from there, You can see here the spectrum of findings in different categories of risk of malignancy and the recommended actions. So it's anticipated that 75% of participants will fall into the category 1 or the very low risk findings. About 14% will fall into the category 2 or the low risk findings, and 8% will fall into the category 3 and category 4, which is low to moderate risk. And for these categories, it is recommended that the participants stay in the program and they return for a follow-up scan at 24, 12, 6, and 3 months respectively. But it's the important minority, the 3%, who will fall into the category 5 that have a high risk, or category 6 with a very high risk finding, where the PanCan risk of malignancy exceeds 30%. And for these patients, it is recommended that they be referred to a respiratory physician who is linked to a multidisciplinary cancer team for further evaluation. And so following referral of these high or very high risk nodules, the patient will then exit the screening program and they enter what we call the nodule diagnostic and treatment pathway, which may exist alongside of services that triage the incidentally detected nodules. But you can see here that the risk of malignancy is different because screen-detected cohorts are much more enriched for high-risk patients. And from there, patients may progress to either having further investigation and treatment after a decision to act. They may continue surveillance through a nodule clinic service, or they might even be discharged and be returned back into the screening program. And at the time when a diagnosis has been reached, it is the responsibility of the managing clinician to then complete this diagnosis form. It includes information like discussion at the MDM, what the eventual cancer status was, the details of that diagnosis, and importantly, the stage at diagnosis. And so to date, just in our first couple of months, we have enrolled close to 43,000 people in the National Cancer Screening Register. Close to just over 39,000 of the low-dose CT scans have been completed. And of these, 1.1% have found high to very high risk findings. We are still waiting for numbers as to how many of these have turned out to be cancer, but just some anecdotes from my own centre, this has turned out to be around a 50% malignancy rate. And when we ask how does this compare with our total eligible population, this is a report that was published last year that estimates the number in Australia by year and by the state that you live in Australia according to the age and smoking history. And you can see in the red box that in the first year of screening, we did anticipate over 930,000 people to be eligible. So we're still some ways off this, but acknowledging though this number does not take into account people who have existing symptoms of lung cancer and those who have had a CT scan in the preceding 12 months. So early lessons. As I've already said, our program is heavily reliant on GPs. And the question is, are we missing vulnerable people who are health service avoidant? And what is the role of lung cancer stigma in eligible people self-identifying to be enrolled? We also have to acknowledge that GPs are time poor and there might be variations in their knowledge as to how to enroll people and how to follow them up. And we are already seeing that while GPs are quite familiar with requesting the scans, only a third of them are actually enrolling them in the centralised National Lung Cancer Screening Register. In terms of the actual CT reporting, we have in Australia around 100 to 450 Australian radiologists who identify as being chest subspecialists. And so we've relied very heavily on general radiologists upskilling in low-dose CT reporting. And there have already been some anecdotal reports of some providers struggling with long unreported lists. We also seen that related to this, that there have been some anecdotal reports of inaccuracies in the reports, and there does need to be a mechanism through which there is feedback and amendment of reports where errors have been verified. And lastly, always electronic integration is slow and it is costly. And in Australia, we do have some limitations with integrating our radiology providers with the National Cancer Screening Register. So there is still a lot of faxed reports going through the system at the moment. And in terms of the impact on the downstream diagnostic and treatment services, this is subject to geographic heterogeneity in Australia. So in terms of respiratory clinics, we have around 86 lung cancer multidisciplinary meetings, but we still do not clearly know how many have nodule-specific services, how many have access to bronchoscopic and nodule sampling infrastructure, and how many have smoking cessation services. In terms of nuclear medicine, we have around 44 PET facilities around Australia. And in terms of treatment, there are around 20 thoracic surgeons, but most of them are located in the metropolitan eastern states. And in terms of stereotactic ablative radiotherapy, we have around 1 linear accelerator per 110,000 heads. So clearly there is some way to go in terms of making sure that our infrastructure is robust. So in terms of program evaluation, this will be the next steps, and we need to think about the direct impacts of the program. Is it effective? Has there been a stage shift? Has there been a reduction in mortality? And what is our reach, particularly to those living regionally and remotely and to those in our Indigenous population? We also need to assess the safety of the program. What is the false positive rate? What is the overdiagnosis of indolent cancers? And have we missed lung cancers that are outside the current eligibility criteria? We are still seeing lung cancers that are found incidentally, and there is thoughts that we do need parallel nodule detection clinics similar to the Deluge study. We need to think about whether we need to widen our age eligibility criteria, such as in the US and in the UK. And we also need to think about, do we need to extend our criteria to never smokers with family histories of lung cancer, particularly the high Asian migrant population in Australia, where there are well-known associations with never smoking family history risk factors. And lastly, we need to think about the indirect impacts of this program. How do we assess smoking cessation rates? What are the actionable additional findings and the burdens they have on our healthcare system? And have we reduced the stigma of lung cancer? And just lastly, building capacity. So there are already moves to standardise the referral and the triage pathways for the high-risk nodule cases. There is discussion about having separate dedicated lung cancer and nodule clinics and MDMs. An expansion of procedural access to have a one-stop shop for diagnosis and staging. And lastly, talking about improving our infrastructure with vendor-neutral archives that allow our radiologists to access historical images. So with that, thank you very much to the ATS, and I invite any questions.
Thanks very much, Tracy. So I encourage everyone to enter your question into Q&A at the bottom of the panel on the Zoom screen, and we will have a discussion at the end of all the talks. So now it's my pleasure to introduce our second speaker, Dr. Jung-Wook Lim. So Dr. Lim is an assistant professor at the Division of Pulmonology, Allergy and Critical Care Medicine at the Catholic University of Korea in Seoul. He's currently a visiting scientist at the Department of Investigational Cancer Therapeutics at the University of Texas Anderson Cancer Center, Houston, Texas. Thanks, Dr. Lim.
Thank you, Gab, for the kind introduction. I'll be discussing the current landscape of cancer screening in Korea. We'll start with lung cancer epidemiology in Korea. As of 2021, lung cancer was the third most common cancer and the leading cause of a cancer-related death. And recent data show about 32,500 new cases diagnosed in a single year. Following the mortality benefit demonstrated in NLST, Korea initiated K-Lucas as a prospective population-based project to generate local evidence before national implementation. The eligibility criteria were designed to align closely with NLST, and the lung-RAS framework was adopted for standardized reporting. K-Lucas evaluated whether nationwide lung cancer screening is feasible, looking at participant selection, screening performance, and safety and quality control and infrastructure. This paper presents interim results from 5,692 participants. The positive screen rate was 15.2%, and the category 4 lesions were seen in 5.9% of participants. There are 42 confirmed lung cancer cases, and 66.7% were early stage. Compared with NLST, the detection rate was 0.7% versus 1.0%, but a higher proportion were early stage cancers. If you look at the updated results, key indicators are similar, and screening positive rate was 15.3%, and the percentage of early lung cancer was 70.3%. The National Lung Cancer Screening Program in Korea was implemented after the K-Lucas demonstrated advantage in detecting early-stage lung cancer. The eligibility framework used in K-Lucas was carried over into the national program. Adults aged 54 to 74 with at least 30 pack year smoking history, including former smokers who quit within 15 years. Screening is performed using CT scanners with at least 16 detector rolls at a radiation dose of 3.0 milligram or less, with a slice thickness under 1.5 millimeters. Screening is offered every 2 years per eligible participant, and smoking cessation education is provided to current smokers. The nationwide rollout began in July 2019. The result interpretation is based on modified version of long-RAS criteria. In the Korean system, category 2B is included here to capture nodules that may appear suspicious by size, but shows definite benign characteristics. Cases within these categories are managed with routine annual low-dose CT surveillance. Category 3 lesions undergo 6 months follow-up, while Category 4A lesions receive 3 months follow-up with optional PET-CT. Category 4B and 4X require immediate diagnostic evaluation, and Category 4X is to describe Category 3 or 4 nodules with additional features or imaging findings that increase the suspicion of malignancy, such as obstructive pneumonia. Eligibility for screening is determined from 3 sources: National Health Screening Questionnaire, recent participation in public smoking cessation programs, and past enrollment in the lung cancer screening program. Korea uses an alternating system based on birth year, and in even number years, only those born in even number years are invited, and vice versa. For 2025, that means people aged 54 to 74 who are born in an odd number year. Eligible individuals are notified by mail, text message, and other media. Participation in the program has been gradually increasing over the years, from 33% in 2019 among the eligible subjects, 46% in 2021, and unofficially about 60% in 2024. Several contributing factors are high accessibility and low cost of LDCT, strong public interest, and continuous nationwide advertising. And if you look at the graph here, you can see that the number of participants increased markedly right after the advertisement campaign began. Let's take a quick look at how the workflow actually runs. Once the low-dose CT is done, the images are automatically sent to the cloud through a secure VPN. They go through CAT, which gives AI-assisted preliminary findings. Radiologists at each screening center review those findings and finalize the interpretation, and the system uploads the final report back to the cloud. Among categories, long RAS 3 and 4 cases are of most interest and under central review. If a center shows unusually high variability, the central review team, including National Cancer Center, provides feedback to maintain the quality. This study evaluated whether the implementation of the national lung cancer screening was associated with mortality benefit. National Health Insurance Service claims data from 2018 to 2020 were analyzed using a difference in differences design. Individuals with a smoking history of 30 pack years or more were assigned to the case group, while those with less than 30 pack years or who were non-smokers were in the control group. The analysis compared outcome between the pre and post-implementation period. Total of 25,908 participants were analyzed. The 1-year all-cause mortality decreased by 3.21%, while lung cancer-specific mortality showed a reduction of 2.69%. The effect was more pronounced in older individuals, non-metropolitan residents, and the patients who visited non-metropolitan hospitals. Overall, this result shows that the nationwide screening program was associated with a meaningful short-term mortality benefit. Korea's intermediate tuberculosis burden means a post-infectious change may increase false positives. As noted earlier, to mitigate this issue, the Korean program adopted a modified version of lung RAS, introducing category 2B to better distinguish benign lesions, of which large proportion are tuberculosis related, from truly suspicious lesions. This nationwide analysis included about 153,000 subjects with a lung cancer detection rate of 0.68%. The modified lung RAS significantly improved specificity and the positive predictive value. There was a mild trade-off in the sensitivity compared with the original system. And in participants with TB sequela, both sensitivity and specificity was mildly decreased. There's a clear stepwise increase in cancer rate across the modified lung RAS categories, and interestingly, category 2B has a higher cancer rate than category 2, which excludes 2B. Looking at the recent lung cancer trends in Korea, especially after 2019, when the national screening program was implemented, we see a steady rise in the proportion of early-stage diagnosis, and the most new cases still occur in individuals aged 60 to 79, making about 65%. Crude incidence continues to increase, but the age standardized trends differ by sex. In men, both the age standardized incidence rate and mortality rate have been declining. In contrast, the incidence rate in women has been gradually increasing, which is highlighted in the graph. As we look ahead, there are some challenges. With the growing number of positive cases piling up every year, there is a relative shortage of trained physicians available for timely follow-up. We are also observing increasing number of LDCT screening among individuals who are not eligible under the national program. And the recent paper showed related risk for overdiagnosis. So these non-eligible groups are paying out of their pocket to get the LDCT screened. As in other countries, there is ongoing discussion about potentially expanding eligibility because relatively few women meet current criteria due to the low prevalence of heavy smoking. There has been consideration of including select high-risk groups among women, and expansion to individuals with lighter smoking histories is also being discussed. Thank you for your attention.
Thank you, Professor Jung Lim, for your brilliant presentation. And we'll go with the question after all the presentation. For next speaker is Professor Conrad Kohlenberg. Professor Conrad is head of pulmonary division at the Stellenbosch University and Tygerberg Hospital, Cape Town, South Africa. He has held multiple leadership roles of the South African Thoracic Society, and he is the current deputy editor for African Journal of Thoracic and Critical Care Medicine. Professor, please.
Okay. Can you hear me and my screen properly shared?
Okay, great.
Okay. Must thank you for this invitation. We are clearly still far behind most countries when it comes to lung cancer screening. Now, South Africa are world champions in at least one thing, and that's rugby. But unfortunately, we are also world champions in many other things that are not so pleasant. We have one of the world's largest or highest TB incidents in the order of almost 500 per 100,000. And to give you an example of how, where I work, this is taken from Google Earth. You see there's a neighborhood called Ravensmead where they have an incidence of 1 in 50 for tuberculosis. So there's obviously a lot of research being done in this neighborhood about TB and TB spread, etc. The other interesting concept that I want to mention is the so-called carcinoma. We have shown that there is certainly at least an association between post-TB lung disease, scarring of the lung, and lung cancer. This is just an association. We haven't proven any genetic or any proof of it. Now, I look at it at CT scans almost every morning, and we see this almost daily. And it's often difficult to say, is this post-TB lung disease? Is this early lung cancer, particularly if you look at the one on the left? That pleural tag probably suggests it's post-TB lung disease. We have another problem. We have the world's largest HIV population. And HIV actually impacts lung cancer. We know that people with HIV get their lung cancer at an early age, and they are much less likely to have curable lung cancer at presentation. We also smoke a lot. There's this subpopulation of our population that smokes, up to 70 to 80% of people who smokes. And this has led to the concept of the so-called colliding epidemics of COPD, HIV, TB, and exposure to biomass fuel, all leading to lung cancer. Unfortunately, I don't have the time to go into the more detail. As with most countries, lung cancer is still the leading cause of death in women and men, of cancer death. So if you're a female, you're twice as likely to die from lung cancer. And if you're a male, you're 3 times as likely to die of prostate cancer. Although if you ask the population, they will know a lot more about prostate cancer and breast cancer. Smoking is probably the most important cause, but we don't know how important genetic drivers, radiation and asbestos exposure and air pollution, what exactly the role is. Now, our journey started years ago, and we already in 2019 published our statement for the recommendations of lung cancer screening. We knew that chest radiographs were considered useless, but a recent study from our institution suggests that there may be a role for artificial intelligence in normal chest radiographs, and we are planning on doing a lot of more work on this. Now, I'm not going to tell you about the famous studies, but I just want to highlight the size that was used in the NSLT study of 4 millimeters, and in the Nelson study of 500 square millimeters. So size has always been a problem. And even early on, there were some retrospective analyses that suggested a cutoff of 6 millimeters may be more appropriate than 4 millimeters. Granulomas from TB can calcify, and they frequently manifest as SPNs, or solitary pulmonary nodules, mostly in the upper zones. We also have the problems with non-tuberculous mycobacteria in HIV-positive patients. And we really don't know what the natural history of these nodules are. Some of them may progress to quite large, way more than 6 millimeters. So when we decided to suggest our lung cancer implementation, we suggested using the revised lung RATS criteria. And as you know, it categorizes nodules smaller than 6 millimeters as essentially negatives, unless they are malignant features. So given the lack of local data, we suggested a conservative threshold of 6 millimeters. And unless there's pre-existing nodules that's demonstrating growth, and obviously we look at the appearance of the nodule itself. Now, we are still on the conservative side, as I saw most of the other countries, using a cutoff of 75 years, 30-pack years, and current or past smokers. Now, our biggest problem in the beginning was to identify centers that can do low-dose CT scanning, and we identified quite many, so that's not a big issue. The major problem is centers that can actually do proper lung cancer management, including proper staging, and there are very few that's accredited at the moment. And so the idea is to link these facilities. And it's also important that we only want to pursue this in patients who are actually willing to undergo lung cancer management and understand the concept of screening. Now, positive nodules must obviously be followed by appropriate investigations. Now, the one thing that we've shown that if you use a PET CT and the SUV is more than 5, then it is a very high specificity for lung cancer. Now, were we correct? Now, this to me is a very fascinating abstract that I saw at the World Lung Cancer Conference in the USA last year, where they looked at 44 studies on almost 500,000 people. Most countries used the lung rats, modified lung rats, as the most common criteria for assessment of positive nodules. And I think the take-home message from this was that the lung cancer screening with a low-dose screening had a comparable positive rate in regions with low TB incidence, and the lung cancer rats is preferable for lung cancer screening in TB endemic countries. And sorry, I can't see something. My apologies. My screen just went slightly blank. Lung rats is preferable in lung cancer screening in TB endemic countries for lung cancer screening, and without increasing your false positive rates. So this was our victory, and it's only happened this year. We finally convinced the funders. Now, these are only, unfortunately, people who have medical insurance. And we had long discussion where patients should enter the program. And because we don't want people, for example, in South Africa, a female can have a mammogram without being referred by a physician. We wanted people to at least have an online questionnaire and see a GP or a nurse counselor to explain the concept of lung cancer screening. As I said, we've gone for the more conservative way of screening. We haven't lowered the pack years or anything. You exit the program, obviously, if you have a positive nodule, and if there's anything, basically, then you'll just continuously do annual screening until you turn 75 or are diagnosed with lung cancer. Now, the cost of a low-dose CT scanning, we were able to negotiate with the Radiology Society of South Africa, and it's actually quite cheap in the US dollars. It's $250 at the moment. We also have tried to start with telling the public about this. We've got trying to early days, but we're trying to get public interest into lung cancer screening. So, in summary, we are still far behind. I cannot tell you. Hopefully next year or a year or two, I'll be able to show you some data. Did it have an impact? How many false positives did we see because of TB or HIV? But as things stand, I don't know. Thank you.
Thanks very much, Conrad. That's a great insight into lung cancer screening potential in the TB endemic area. We'll have further discussion in the panel. So it's my pleasure to introduce our final speaker for today. So Professor Patricia Rivera. So Dr. Rivera is a professor of medicine, chief of the Division of Pulmonary and Critical Care Medicine at the University of Rochester Medicine Center. And she is the Associate Director of Diversity, Equality, and Inclusion at the Wilmot Cancer Center. And Patricia has served as the President of the American Thoracic Society. Welcome, Patricia.
Thank you so much. It's a pleasure to be here. I am going to speak on approaches that have been investigated in the United States to reduce disparities in lung cancer screening. And as my previous colleagues have noted, lung cancer remains a serious problem worldwide. It is the most lethal cancer known to humankind. In 2025 in the United States, you can see the numbers, approximately 110,000 new cases in men. And in 2022, we saw for the first time an increase in the incidence of lung cancer in women in the United States, and that trend has persisted. It is a leading cause of cancer death in both men and women in the United States, as it is in over 23 countries. And for decades, we did not have a way to early detect this lethal cancer in the United States. That changed after the NLST was published. Lung cancer screening was approved by the Preventive Services Task Force in 2013. Medicare, which is our national health service, if you will, for people over the age of 65, approved it in 2014. And in 2021, as you know, the criteria was revised, to lowering the age and the pack year smoking history, although if you've quit within 15 years, you're eligible. That has not changed. Although we have been screening for now more than a decade, we have had significant challenges implementing lung cancer screening across the United States. The process for lung cancer screening is complex. Not only do you have to have access to a lung cancer screening program, but then there are multiple steps, including assessment of the eligibility for the scan, ordering the scan, following up on the results, ordering the annual low-dose CT if the results are negative, follow-up after a positive, referral for smoking cessation, and follow-up incidental findings. And a lot of individuals sort of get lost, if you will, and there's a significant potential for leakage across this process, particularly for vulnerable populations in the United States, Black individuals, Latinos, Native Americans, people who live in rural areas, and people who are under or uninsured, to mention a few. Eligibility assessment has been problematic, particularly for populations that may have higher risk, even though they smoke less. We have revised the criteria in 2021 to include more of these individuals, but disparities still exist. We struggle with low rates of uptake, about 20% nationwide. Again, for a screening scan that saves lives and detects the most lethal cancer known to humankind. And we struggle with low rates of annual adherence, people coming back every year after a negative CT. If you don't come back annually, the benefits of screening are not realized. People not coming back timely when they have a positive screening CT, people who live in rural areas and have social determinants of health, such as inability to get it transport to a facility, struggle, and the financial burden. Yes, this is covered by insurance, and yes, this is covered by Medicare, but there are a lot of individuals in the United States under the age of 65 who do not have health insurance. In 2020, I led a research statement for the American Thoracic Society to address the disparities in lung cancer screening, particularly eligibility. This was before the revision of the USPSTF criteria, but also to address the challenges in terms of healthcare access. And we found multiple barriers at both the healthcare system level, the patient level, the clinician level, and geographic location, also a major barrier, and identified multiple areas, again, along the screening process where there is significant potential for leakage, if you will. We also proposed at the time strategies that we felt needed more research. Again, this was meant to understand the gaps and what are the potential solutions for these problems. In particular, at the time, this was before the 2021 revisions, we felt that the eligibility assessment needed to be revised because, again, the original criteria were not inclusive of high-risk individuals, particularly Black men and women. We identified patient navigation as a potential important intervention to mitigate disparities in rural populations, mobile screening units as a way to get to individuals who do not have access because they don't have transportation, and also propose policies that mandate expansion of Medicaid coverage. That has significantly happened over the last decade since screening was first introduced in the United States. So individuals who are not yet eligible for Medicare, but who are of low socioeconomic status and are eligible for Medicaid have access to this very important intervention. In the United States, we have to remember that the smoking prevalence, the lung cancer incidence, and the lung cancer mortality varies not just by sex, but importantly by race and ethnicity. Black men in the United States shoulder the burden of lung cancer risk and lung cancer mortality. Native American, Asian Pacific individuals also have a high burden of smoking prevalence. And again, in the United States, when you look at the pack year smoking history in Black individuals compared with white, Black individuals tend to smoke less than white individuals, cumulative and throughout their lifetime. This was a very nice study that was done in the United States, looking at the southern cohort, and it looked at individuals that were diagnosed with lung cancer, those who were white and those who were Black, and how many of those who were diagnosed in lung cancer were not eligible for screening and why. And as you can see, when you compare white and Black individuals were less likely to have the 30-pack year criteria, therefore less likely to be eligible for screening. This was another important study published in 2018 that looked at the prevalence of smoking among women born since 1965, and it showed that while smoking rates were approaching that of men in this age group, they were not surpassing that of men in this age group, and yet mid-adult white, Asian, and Latinas in the United States were found to have a higher incidence of lung cancer. Again, they were not smoking more than men. The assessing or eligibility criteria based on age and smoking is very practical for identifying screen-eligible individuals in the population, but it may be overly simplistic because risk of lung cancer varies among groups of individuals in the population, and many have promoted using risk modeling based approach. In other words, assessing risk using other variables that contribute to lung cancer. The prostate, lung, colorectal, ovarian model is one such model that has been proposed by many investigators. This incorporates not just age and smoking history, but also race, education level, other risk factors such as chronic obstructive lung disease or emphysema, personal history of cancer, or family history of cancer, important risks for lung cancer. Several individuals, and I'm just going to briefly touch upon them. This was a study that we did back in 2020, and we looked at incorporating the life years gained from screening CT model, a risk model, incorporating it into the USPSTF at the time revised criteria that were coming out. And we noted that incorporating risk modeling into the USPSTF approach to screening eligibility eliminated disparities for Black Americans, and it improved the efficiency for Asian and Hispanic Americans. Other individuals have recently looked at risk-based screening using the PLCO, but a recalibrated PLCO 2012. The original PLCO 2012 did not calibrate well for race, so this is a new model. And using a 6-year risk of developing lung cancer of 1.3%, they noticed that there was a reduction in the disparity between eligibility and incidence of lung cancer, eligibility for screening between Black and white individuals, a significant reduction in that disparity. It yielded superior overall race and ethnic specific performance to USPS 2021, although a not significant change in the disparity. And others have looked at incorporating risk-based modeling to USPSTF criteria to see if it improves the eligibility to incidence ratio, and it does indeed attenuate disparities, particularly, of course, for women. This was a recent study that examine multiple strategies that have been studied to reduce the disparities in lung cancer screening uptake in the United States. And it compared these strategies and these studies in states that had expanded Medicaid, which was really important intervention, versus those that had not. The majority of the focus was in racial and ethnic minority groups, although several studies have looked at low-income groups and rural communities. As you can see, the majority of the studies in states that expanded Medicaid were conducted in hospitals, whereas community-based interventions were more commonly studied in states that had not expanded Medicaid. But the major theme, if you will, of interventions across these 37 studies was community outreach, particularly among individuals who lived in states that had not expanded Medicaid, decision aids to help physicians and nurse practitioners better identify patients and better conduct shared decision-making, and patient navigation, which was robustly investigated both in Medicaid expansion and non-Medicaid expansion states. As I mentioned, most studies focused on disparities by race and ethnicity. The review highlights that there are many differences, but also many commonalities in implementation strategies that address lung cancer screening. But the multitude of strategies that are investigated highlights that this is not a one-stop intervention. This is going to require a multi-pronged approach, multiple interventions, if we really want to address lung cancer screening disparities. There's a lot of variability in the effectiveness of these interventions reported, and that just highlights that there's a lot more work that needs to be done in this area. And the prevalence of patient navigation strategies studied in both groups, those that live in states with Medicaid and those in non-Medicaid expansion, navigating, because that's the purpose of these patient navigators, helping the patient navigate to the screening process is important, because that may indeed be a major intervention to address a major barrier. And indeed, patient navigation has been shown to be probably one of the most effective methods of improving screening, particularly among low-income populations and people who live in rural areas. This was a very nice study that was conducted in Boston in a homeless health care shelter for individuals who have experienced homelessness. Individuals were randomized to either patient navigation, which was the intervention, versus usual care. They had a primary care physician that would refer them to screening. But again, a lot of these patients were not routinely being seen by a primary care physician. And the primary outcome was how many individuals received the baseline low-dose CT within 6 months of being randomized. And as you can see, patient navigation significantly improved getting patients to that very first low-dose CT, 43% of individuals. And these are really vulnerable individuals. These are individuals experiencing homelessness compared to those that did not have the intervention. Another important intervention that has been explored is the use of mobile low-dose CT units. This has historically been done for breast cancer with the mobile mammograms. But does this improve outcomes in underserved populations? Again, we're talking about people who have very difficult time getting to a facility because they live far away from the major center or the radiologic facilities that provide low-dose CT, but simply do not have means for transportation. And in this pilot study, again, they targeted individuals who were uninsured or underinsured that were eligible for lung cancer screening. They enrolled 550 patients, 1-to-1 to 1 male to female ratio. The median age was 61, 20% Black individuals, 3% Latinos, and the majority in rural areas. Cancer detection was 2.2%. 58% of the cancers were stage 1 or stage 2. And the conclusion was that this is an effective means to get to patients who are in these very vulnerable areas where they have no access to lung cancer screening because they cannot get to the facility, or they're uninsured or underinsured. And again, an important intervention, particularly for underserved populations. And the last approach that has been shown to be effective in terms of mitigating, improving adherence, but also mitigating disparities, is the role of centralized lung cancer screening programs. In the United States, we have two processes. We have decentralized screening, meaning any physician or nurse practitioner, after shared decision-making, can order a low-dose CT. And in the United States, that is primarily the role of the primary care physician. But many centers throughout the country have developed this centralized approach with multidisciplinary teams modeled pretty much after multidisciplinary lung cancer programs, which many of us developed, 25 years ago in the United States. So a group of individuals, primarily pulmonologists, thoracic surgeons, thoracic radiologists, primary care physicians, individuals who have expertise in nodule management, again, to deal with those positive low-dose CTs and to ensure that there is timely follow-up, incorporating primary care physicians to help with the management of the unexpected or incidental findings, like the coronary artery calcifications, incorporating tobacco treatment specialists so that you can have a screening program that at the same time of referring to low-dose CT, you are referring individuals to smoking cessation, which is the most important intervention to mitigate lung cancer risk and mortality. Nodule tracking programs have been shown to be important in terms of not just tracking the nodule, but really tracking individuals across the entire process, if you will, the continuum from when the nodule was detected, the follow-up scan, the procedure necessary if there's concern, referral to the appropriate specialist, either surgeon or radiation oncologist or medical oncologist, and having a registry that can help you evaluate outcomes of your screening program. What is your completion rate after you order that low-dose CT? How many of your patients are coming back annually after a negative low-dose CT? How many are coming back timely after a positive low-dose CT? How many got enrolled in smoking cessation and were able to stay quit? This is really important because we can really assess the benefits of screening in the population without these data. And it is a programmatic process. It's a coordinated screening process, again, across multiple individuals with expertise. Not an easy thing to do, but an important intervention to mitigate disparities. And this was a recent study published looking at the rate of annual adherence after a low-dose CT and whether or not a centralized versus decentralized program made a difference. The investigators identified 12 studies over 17,000 patients with a reported lung RATS 1 or 2 or a negative baseline low-dose CT who reported adherence between 10 and 18 months. And some of us would argue that we really should stick to the 11 to 15 months, which is what the NLST defined as annual adherence. But nonetheless, some programs have expanded it. There were only 4 studies with about 17,000 patients that reported adherent outcomes for both centralized and decentralized approach. The overall pooled adherence across all these studies was only 55%. Now that's better than what many of us have reported individually, but 55% is still not enough. There was a modeling study that showed that if adherence was dropped from 100% to 50%, the benefit mortality reduction of lung cancer screening also halved. So for screening to work, annual adherence and adherence to follow-up after a positive CT is critical. When we look at the studies that reported centralized versus decentralized, you can see that adherence significantly improved in centralized programs, 68, almost 69% compared to 37% in decentralized programs. So lung cancer disproportionately affects many different groups in the United States, Black men, women, and socioeconomically disadvantaged groups. Implementation has been challenging. There have been multiple barriers identified across the entire lung cancer screening continuum. And beyond pack years, smoking, and age, risk prediction models may be very beneficial. Combining risk prediction with USPSTF criteria has been shown to mitigate disparities in eligibility incidence ratio, particularly among Black individuals, and improve efficiency across other groups like Asian and Latinos. Expanding the eligibility criteria, however, is not enough to mitigate disparities. We must continue to evaluate strategies that can improve outcomes. Again, patient navigation is probably the one intervention that has been shown to be very effective in rural communities and among disadvantaged groups, screening mobile units, centralized screening programs. But there's a lot of effort in the United States to continue aggressive community outreach. The role of telehealth visits to conduct that shared decision-making may make an impact, and mobile technologies with bidirectional texting to navigate patients to lung cancer screening. Thank you.
Thank you, Professor Patricia Rivera. I'd like to thank all the speakers for sharing their valuable experiences and perspective from different parts of the world. And it was truly fascinating to see the unique approach in each region. And now let's open this for discussion. And we welcome any question or comments, and you can put your Q&A in the Q&A button below the Zoom. And we have two questions from Muhammad Abdal Mohsen. And first question is goes like this. I attended the British Society Oncology meeting earlier this year, and despite screening, the rate of emergency lung cancer prevention range around 30%. Are there similar figures globally, and why do we think this gap persists? Do you have any comment?
I want to ask what do we mean by emergency lung cancer prevention? Is that getting patients, you diagnose the cancer, but patients are not getting appropriate care?
I think he meant that there are still many patients that are diagnosed in the emergency room accidentally. Yeah.
I mean, I can take a stab at this because in the United States, many uninsured or underinsured individuals rely on the emergency room for their care. So they don't have established care with primary care physicians. And often they're presented to the emergency room with respiratory symptoms and are undergoing CAT scans, either non-contrast or contrast CAT scans where cancers are detected. Here at the University of Rochester, a colleague of mine, an emergency room physician, is actually studying the providing an intervention for individuals who seek care in the emergency room for other things, who are eligible for screening, to help navigate them to not just lung cancer screening, but cervical cancer, mammography, colon cancer screening. So yes, in the United States, many individuals rely on the emergency room care for their primary care. So that may very well be why there's that gap, because they don't have primary care physicians.
Yeah. So is there any comments to add on? Maybe Dr. Tracy or
Yeah, I wasn't certain if the question referred to incidentally detected lung cancer. I was also a bit confused by the word emergent. And certainly in Australia, and I'm sure it's similar around the world, that a significant number of lung cancers come to us through non-screening pathways. They're picked up when people have accidents and come through emergency department. They're picked up because GPs are doing scans for other purposes like cardiac disease scans, and they're finding lung lesions. And for us, that number is approximately 20 to 25%. So it is a significant number. And as to reasons why there are still cancers coming through that pathway, I think it comes down to the risk factors. Currently, our screening program is based on age and smoking, but as we've already discussed, never smoking lung cancer is increased in certain parts of the world, and certainly at younger ages and in females. So we are going to miss a proportion of these with our sort of more stringent eligibility criteria.
So I
yeah.
can just briefly add that, the proportion of lung cancer diagnosed through lung cancer screening is still relatively small among all lung cancer cases, because lung cancer screening is not designed to detect all lung cancer cases, but rather to reduce maybe lung cancer specific mortality in a select high risk group.
Yeah, actually, I was very curious because there is increased number of non-smoking lung cancer, and currently there is a small gap between that, and maybe we may develop like AI model to more selectively select patients with higher risk of lung cancer or non-smoking lung cancer. Do you have any comments for non-smoking lung cancer screening?
I can tell you that in the United States, it is challenging. I mean, we can, the rates of screening are low for those who are eligible. But I think it's just really challenging because we have really, at least in the United States, we don't have any data yet. There is an ongoing trial looking at screening in Asian women with a family history of lung cancer. But we don't have any data. At what age do you begin? What other criteria? Should it be limited to only individuals who have identifiable risk factors like family history or personal history of cancer or radon exposure? It's very, very challenging. And I think that we have to be, I'm obviously I've been taking care of lung cancer patients with lung cancer for 25 years, and I'm passionate about this topic and screening. But I think we have to realize that while the benefits are there are also potential risks. And we have to be very careful that we're balancing. Screening is not done at an individual level, it's
Yeah.
always done at a population level. And that's, I think, been the challenge.
So maybe we can this never smoker female lung cancer incidence increase is a major topic these days, and there's a lot of people speculate that there may be a synergistic effect between genetic predisposition and the
Mhm.
exposure to the air pollution. So I think there was some couple of very key studies showing that, and within 5 years, I think we're going to have some strong results
Yeah.
regard to that. And in Taiwan, I believe there's a cohort study called Talent Trial showed that
Mhm.
when they screened the never smokers, they showed that the cancer detection rate of 2.4%, which is higher than the other lung cancer screening programs, and that they likewise they targeted the relatively high risk groups, such as exposing the high lung exposure to the indoor pollution, not using hood when cooking. I think that's something that we should
Yeah.
look for.
I do. I think for me, what the talent study highlights is how critically important is the family history of lung cancer. Because they included, women age 50, starting at the age of 50, some had very light smoking, light smoking, or non-smoking history. But the overwhelming majority of the women diagnosed with lung cancer, I think it was something like 90%, were women who had a family history of lung cancer. And I think that for me, that's a very important risk, particularly when that family member is also a woman, right?
Yes.
And in my lung cancer screening, we have a centralized program. I incorporate risk modeling. So I calculated a PLCO 2012 risk on every patient that I see. I I I am referred a lot of patients who don't meet smoking criteria because the primary care physicians don't know what to do. And I take a very thorough history and family history, prior history of cancer. I take very serious. And this is all done in the context of, I have a registry so I can track these patients. But if the risk is there or there's a strong family history, I advocate for screening.
We do the same, Patricia, as well.
But again, it's in the context of, I have a registry, we're tracking patients, we have a multidisciplinary panel of clinicians who reviews all positive CAT scans. So being mindful that, we're just not nilly-willy, we have to be really thoughtful. And I always discuss the potential risks, but it is very challenging. Age and smoking is just, it's overly simplified, but it's the best we have now until the future when we can really incorporate genomics and radiomics. I think we're going to be able to do much better.
Okay,
Agree.
thanks, Patricia. And moving on to the next question. And second one is in TB endemic areas, is there a higher incidence of non-smoking related lung cancer? So maybe this question goes to Professor Conrad.
Look, I've published extensively on patient profile. About 91% of people are smokers. In our population, it's so difficult. I spoke about the colliding epidemics of TB, HIV, smoking. And unfortunately, we do also see these young women. So we see that. But there's also a great biomass fuel problem in our country. So it is so difficult. I wish I could answer that question, but there's so many confounders that it's basically impossible. I mean, there's just 9% of people that smoke, but we also have a big mining. There's rural areas that use a lot of biomass fuel, so it is a complex story. And I wish there was a simple answer. As I also alluded to, there is a possibility, there's at least this concept of a carcinoma, for example, that TB may in itself be a risk factor for lung cancer. And we at least show that there was an association. But I wish I could answer that answer. I mean, give you an answer. It's certainly something that needs to be studied, but to study it properly would be a major undertaking. I don't know I mean, Korea is also, I think, perhaps a country that
Well, there are some studies showing that the TB actually increase the risk of lung cancer development maybe by 1.7 to 2 double fold. In multivariate model, I think the similar result was shown in Taiwanese study. But I think incorporating history of past tuberculosis as in part of the prediction model, I think it's a different story. Like Patricia has commented, we have to measure all the impact of each parameters. So definitely there is some increase in lung cancer risk in patients with past tuberculosis, I think.
Thanks, June. And I think that kind of linked nicely into the next questions. I think I might start with you, June. That I think all of you have mentioned that smoking cessation is one of the crucial part as part of lung cancer screening program, and all the programs that you've described has kind of built into in the system to address this issue. I will start with June. How successful do you think this lung cancer screening and incorporating smoking cessation into that program, and how successful is that approach to get patients stopping cigarette smoking?
Yeah, I think this is a very important question because if you leave the root of the problem, it will still continue to cause problems. So I think I cannot give the exact number of how the smoking cessation happened, but the pilot prospective study I mentioned, K. Lucas,
Yep.
they had a assessment on how patients felt confident in stopping smoking. And the paper comments that they concludes that smoking cessation program was successful in making participants feel more confident in quitting smoking. I think the closest answer I can give to the question. And as a physician in Korea who participated in a smoking cessation, I think we not only like tell participants just quit smoke, but also there are some how do you say reward for like if you sustain smoking cessation for maybe 12 weeks, there may be some could be I believe there was some monetary reward. And there were a lot of approaches, not only doctors but nurses and social workers are they work together to make this work. Yes.
Great, June. Patricia, it has been 10 years in US. How successful is the smoking cessation as part of cancer screening program?
So I can tell you that again, the data is variable. There was actually a recent study, I want to say it was published in either April or May of 2025, that looked at lung cancer screening program and smoking cessation, but randomized patients to, I think it was 4 weeks of counseling and pharmacotherapy versus 8 weeks. So a longer, provided by telehealth with not only longer counseling, but longer pharmacotherapy. And they actually showed that providing longer counseling was associated with improved rates of abstinence, both at 1 week and at 6 months. The relative difference or the risk difference, I think, was about 6%. Interestingly, longer pharmacotherapy did not impact the rate of abstinence. It remains a challenge. It remains a challenge. You know, when I was at UNC, at the University of North Carolina, we had the smoking cessation program was part of the lung cancer screening program and part of the multidisciplinary lung cancer program. So it was easier to track. Here in Rochester, we have 3 different programs, one through the cancer center, one through primary care, one community-based. So it's very challenging. The key is asking individuals at every follow-up annual exam whether or not did they keep their appointment, were they successful. I refer every single patient who is smoking to the smoking cessation program when I order the low-dose CT. And I tell patients this is in parallel to screening. You can do really, to get the benefit, you must do both. And remember that in the retrospective analysis of the NLST, individuals who quit smoking and stayed smoke-free for the 7 years that the patients were followed, the relative reduction in mortality was 38% versus 20% over. So there's no doubt that, and that benefit was, at least in the US, was mostly seen in Black individuals. So there's the benefit of smoking cessation cannot be discarded, and I think it's a critical component of any lung cancer screening discussion in a lung cancer screening program.
Thanks. And we have another 5 minutes left, reminder from the ATS, and we might just address the final questions. And we might start with Tracy. So the last question is dealing with ancillary findings from low-dose CT screening. So for instance, ILAs that might be picked up on the lung cancer screening. How do you anticipate the workload on how that GP might, because in Austria it will be first result go to the GP, the primary care physicians. How do you think this might be addressed?
Yeah, so I think the rate of interstitial lung abnormalities is anywhere from around 5 to 10%. And certainly in Australia, we have a sort of a guide with regards to what we call actionable additional findings. They're around sort of 29 to 30 findings, which are thought to be important to be included in the conclusion of our synoptic radiology reports. And in that, there are links to recommended guidelines for general practitioners to use. So, for example, with ILAs, there is discussion about differentiating sort of mild, moderate, and severe findings. And then from there, whether that requires then onward referral to a respiratory specialist usually, or if this is something that can be monitored and perhaps other testing like lung function testing. So for us, it is the sort of burden of ILA assessment is largely borne by general practitioners, but there is a lot of guidance as to what they can use to help them.
Great. Thanks, Tracy. And any quick comments from Joan, Conrad, and Patricia about ancillary findings? How easy that can be dealt with, or how difficult that can be?
I think it's a significant challenge. We published an ATS research statement, I want to say January or February, that highlights the gaps in this area and how challenging this is. And it's a multi-level problem. It's for patients, it's for the primary care physician, for the radiologist, for the ordering physicians, for the pulmonologist. The American College of Radiology in the United States did create sort of a quick reference guide for radiologists, but even the reporting of incidental or unexpected findings is very heterogeneous. Assigning the S modifier, which is the lung rats, to address something that is important, is very heterogeneous. Who should be in charge of following is unclear. I work very closely with primary care physicians, and I rely on them to help me with any non-pulmonary incidental findings. But it is daunting, and it's likely to become more of an issue with automated radiology assistants and reports that can, pick up very subtle things. And I think, the big question is this really a risk of screening, or is it a benefit? You can look at it both ways. It's a risk if you're going to be doing a lot of imaging and cause a lot of stress and downstream procedures. But if you find severe coronary artery disease, or if you find, renal cancer, I've detected 2 breast cancers on low-dose CT. Then that's a significant benefit. All-cause mortality in the NLST was better in those who were randomized to low-dose CT. It wasn't statistically significant. It was likely because of the coronary artery calcification. But there's a lot of benefit, and some argue that for the big 3, emphysema, coronary, artery calcification, osteoporosis or osteopenia, which carries a significant burden in patients with COPD in terms of morbidity and mortality, that these things can be detected on low-dose CT.
Yes, I think there's a logistical component in this issue. There will be a lot of findings piling up every year. But who will see it? Is it going to be only pulmonologists or cardiologists for coronary calcification? And I don't know, maybe the option is maybe provide easy guideline for the physicians who are not pulmonologists or cardiologists. I think this issue should be dealt after discussion among various professionals.
Okay, thank you all. And we have now reached the end of our session. And just a quick administrative note before we close. This session has been recorded and will be made available in 1 or 2 weeks. A link to the recording will be sent to everyone who was registered. So I'd like to express my deepest gratitude to our distinguished speakers for their valuable insights and to the audience for your active participation. And thank you, and I hope to see you at the next meeting. Goodbye.
Thank you.
Thank
Bye-bye.
you. Bye-bye.